Hi, folks. Welcome to the Award Network webinar. I'm just going to give another minute as we let people in from the waiting room. All right, good morning or good afternoon, depending on where you are, whether you're on the East or West Coast or somewhere in the middle. My name is Bianca Frogner. I'm a professor at University of Washington in the Department of Family Medicine, and I direct the Center for Health Workforce Studies. And I'm also the chair of our webinar committee for the Award Network. Here we are again for our November monthly webinar series. It's so great to see so many of you join us today. Today, myself and Joanne Spetz, the PI of the Award Network and the director of the Award Network, will be speaking to you about public data sets that can be used to look at the dementia care workforce. So thank you so much for joining us. As always, these sessions are recorded and you can find them online on the Award Network website under the webinars section. You can also scan the QR code in the bottom right-hand corner to find our past recorded webinars, as well as register for future ones. But we also want to hear from you. If you have ideas for future webinars, we are always happy to hear about them. Because of you all, we are able to actually pull together such a wonderful array of webinars. And we're excited to share that we have one upcoming in December 6th. We have the guide model that's going to be discussed that comes out of CMS, and we have some of our colleagues from CMS who will be speaking on the guide model, discussing what it's about and what the implications are for the dementia care workforce. So I hope you all do get a chance to join us for that. And again, you can sign up and register for that via the QR code. And always feel free to sign up for the listserv, as that's the best way to really stay abreast of what else is happening with the Award Network. I just want to give a note that in the new year, in January, we're not going to give the webinar on the first Wednesday of the month because that's right at New Year's Day. So we will do it on the second Wednesday in January. So just want to give a heads up. We'll try to get the January webinar topic and registration up online so you can get that onto your calendars. And as always, I want to thank our wonderful webinar committee who's worked very tirelessly in the background, trying to get our webinars organized and get these together. And they've also oftentimes served as hosts. So I want to thank them very much. And I want to give a heads up about a summer institute. This is really exciting as we get some details into place. A summer institute will be taking place in San Francisco next summer, July 15th through 19th. So please mark your calendars. We're hoping to provide some stipends to support up to 16 people to join our summer institute, where you'll learn more about what it means and what it takes to do research on the workforce to care for patients living with dementia. And more details will come. So we just wanted to start announcing this because we know, even though we're still here in the end of 2023, summer plans can quickly get eaten away with other plans. So mark your calendars. Again, sign up for a listserv, and that's the best way for you to hear about more detail. And I'll try to give more details in future webinars. And I do want to make sure I acknowledge our funders, the National Institute on Aging, who's been supporting our research here today. Or in all the, supports all of our webinars that we're presenting today. So with that, I guess I'm going to turn it over to myself. I don't know that I need much of a background or introduction, so I'm going to just take a moment here to just switch screens and pull up my other slides for today. So just give me a moment. So again, my name is Bianca Frogner. I'm part of the leadership team here in the Award Network, and also helping chair the webinar committee. And I will be speaking to you today about public surveys and what some of these public surveys may be able to say or not say about the dementia care workforce. And it's really a brief overview that I'll give, because I can certainly talk about this for a long time, and I'm more than happy to answer any additional questions as after the webinar if people have questions. We will hopefully leave some time here at the end of today's webinar to be able to do some Q&A. So feel free to pop your questions into that Q&A box at the bottom of your screen, and we'll facilitate a conversation at the end. I will be passing on the baton to Joanne Spetz, who will be speaking about some new and exciting work that has been awarded to UCSF and University of Michigan on new large public surveys that will become available to you all with some pilot funds, and Joanne will speak more to that. And at the end, we'll have Lei Chen, a postdoctoral fellow with the Award Network, to share some of the ongoing work happening within the Award Network on a data compendium that she's pulling together with other colleagues here to highlight some additional information and detailed information on data that can be used to examine the dementia care workforce. So with that, I'll go ahead and get started. So I do have just a few objectives I hope to get across today. One is to just identify what kind of data sources might be out there that capture some counts and characteristics of the US health workforce broadly. There are many limitations to these data sources, so I want to give some things to think about those limitations because they are significant, and this is really why the Award Network is here today, is to help improve data collection in this arena, help inspire other ideas about how we can leverage existing data, but also think about new ways to collect data on the health workforce to care for patients living with dementia or Alzheimer's. And that's really the third objective of today, is that I hope that this, if anything, just gets the juices going, gets the brain thinking about ways that we can look at the health workforce in this arena. So before I actually talk about all the specific data, I do want to have some starting points for you all to know about where I'm coming from, what we kind of know about the existing data that are out there. So we often are relying on data that are not specific to the health workforce when we study the health workforce. And that's going to be a theme that you'll see as I talk about the various data sources today. There are lots of data that are out there that study the broader economy and study the broader workforce. And a lot of times those are some of our best data that we have on some, especially our unlicensed workers. So we have to recognize the limitations that comes along with the fact that data may not be specific to just healthcare. And so not all the questions that we want to have answered are always available. And a lot of times today, we're working on workforce data that are not specific to dementia care. A lot of times these data that we're looking at and relying on are organized by specific settings, whether it be a hospital setting or ambulatory care setting or long-term care setting, or in specific segments of the workforce, like the physician workforce or the nursing workforce. And it's not often that we have opportunities to study all the different kinds of workers in one data set. The workforce for caring for patients with dementia or with Alzheimer's, that workforce is quite broad. There's not a well-defined or single group of people that care for people with dementia. Dementia touches the health system. Patients living with dementia touch the healthcare system in many different ways, whether it start in the primary care setting where dementia may be first identified, to specialist offices, and then later on, maybe there'll be a role for physical therapists, there's a role for pharmacists. And then we do know that long-term care certainly plays a very important and key role in the latter stages of dementia and Alzheimer's care. There's care that's provided in the community as well as in institutional settings. So the point is basically that the workforce caring for patients living with dementia is broad, it's across multiple settings, and that's just something we have to recognize. Unpaid caregivers are a critical part of care for patients living with dementia, and they're oftentimes not included in workforce data that are available. Oftentimes, because they're not paid, it's not so easy to identify a clear way. It's not always easy to identify clearly a way to identify those caregivers that are out there. Though certainly there's a good set of folks out there who are doing research to improve our understanding of the unpaid caregiver workforce. And so therefore today I will highlight where I think one can find unpaid caregivers in here, but for the most part, I will not be able to identify that group as I talk further. When it comes to healthcare workers or workers caring for patients living with dementia, connecting the characteristics of those workers to actual patient outcomes is really difficult and very limited. But this is increasingly improving, and I think that's an exciting part about looking out into the future, is that there's so much data that's emerging. And so that means that there's many opportunities to connect those data sources. But to date, we don't have very many public sources that connect these two sets of information. But that is a lot of times considered a bit of a holy grail, is to understand the workforce that's caring for the patients and putting those two pieces together. So I'm going to go ahead and dive into the actual public sources that may be out there. This is not a comprehensive list. I'm sure there are even more, but I did my best to highlight the many surveys that are out there. I will share my slides afterwards. I'm more than happy to find a way to put that onto the Award Network website, because what I do have here are hyperlinks to the actual surveys so that you can learn more information about each of these surveys. So I broadly lumped some of these surveys into cross-sectional surveys and longitudinal/panel surveys. And I'll do a little bit more of a deeper dive on a few of these. I'll go into a little bit more detail about the American Community Survey, the Occupational Employment and Wage Statistics, and the Current Population Survey. But it's certainly worth noting that there is a mix of surveys that exist out there that are focused on an individual and asking individuals about their work situation, such as it's done for the American Community Survey and the Current Population Survey. But then there's other surveys that might be about a setting in which there's questions that are asked about the kinds of folks that work in those settings. Like there are a number of national healthcare surveys that are residing with CDC under the National Center for Health Statistics, and some of you may be familiar with some of these surveys because you may have come across it in for other reasons, like the National Ambulatory Care Survey, or NAMCS, or the National Hospital Ambulatory Medical Care Survey, or the NAHAMCS. Those two surveys are publicly available. They have questions about the different kinds of workers that may be working in these settings. And similarly, there is probably most relevant to folks here in the room, the National Post-Acute and Long-Term Care Study, or NPALS. NPALS used to be called the National Study of Long-Term Care Providers. And this set of surveys identify what type of staffing might be existing in residential care and adult daycare facilities. Other than those sets of surveys, which are, again, kind of based on the employer, the one other survey that exists that is employer-based is the Occupational Employment and Wage Statistics. But that is a survey that's looking across all parts of the economy, not just healthcare. And I'll talk a little bit more about some of the pros and cons of some of those data sets. There are a number of I should mention that there is the National Sample Survey of Registered Nurses. Again, this is not a dementia care specific workforce. It is looking at all registered nurses across the United States. It is a sample survey, and it has been done every few years out of HRSA, the Health Resources and Services Administration. And there is a new set of public data that will be hopefully released. We're crossing our fingers here at the end of 2023. The look back period was in 2021. And then the last data that were available were released in 2018. The data are, as is the case for all of these data, are reliant on federal dollars being available to be able to continue ongoing data collection for these. And fortunately, HRSA has worked hard to try to get a regular rhythm to collecting data on the registered RN workforce. And I'll talk a little bit more in detail about what some of these data sets are collecting to later on, in terms of thinking about what some of the pros and cons are of some of these data sets. Among the longitudinal/panel surveys, I will talk a little bit more about CPS, the Current Population Survey, which again is a national data set of all types of all types of workers. And there are a number of other surveys that exist out there that have different elements of longitudinalness to it. There's the Health and Retirement Survey, which focuses on folks aging later into life. It is a panel survey. That is a place that people may have used this survey to look at patients with dementia or living with dementia, to look at it from that perspective. I do know that there are some occupational codes in there, but they tend to be very broad. So, so that is a limitation of that data set. There's a panel survey of income dynamics, which we have used before in my center to follow cohorts of people who are picked up over time, and there are detailed information about people's occupations. So you can identify healthcare workers with pretty good detail, and you have a lot of information about their income over time. However, the challenge is that it is a relatively small data set. The National Longitudinal Survey of Youth is similar in that sense of having a somewhat detailed level of information on occupation. You have a lot of details about their life. However, the sample size is quite small. The slight difference between NLSY and PSID is that NLSY follows a certain cohort of people over a long period of time. And there was a cohort of people recruited in 1979 and then again in 1997. So those two cohorts of people have been constantly surveyed over time, so you can follow the same people over time and follow their career trajectories. The Survey of Income and Program Participation, or the SIP, is also another kind of a panel survey where you can follow folks over a period of time. People are kind of recruited at different periods of time. And again, good detail on occupation and income, a challenge of similar to NLSY, and PSID is the small sample sizes. So you're probably getting a flavor. Many different public data sources that exist out there, each with slightly different study designs, different sample sizes, and different perspectives. And so a lot of times the choice of the data set is going to come down to what is your question, from what particular angle are you looking at? There are going to be trade-offs regardless which direction you go forth with. But the reason why I'm emphasizing public data sources is that they're available and they're free. And while there are some costs associated with just making sure you have the right infrastructure to run the data sources, that is probably the biggest thing, is being able to access data for free. There's a lot of advantages to that. And we certainly can thank a lot of federal grant dollars for making these surveys live and exist. So I'm going to, before I dive into some of these data sources in a little bit more detail, I do want to acknowledge that there are other sources of workforce data, some of which are public, some of which are not. And I'm not going to go into these as much, but certainly it's worth kind of noting other data sources that can be used. There are a number of public administrative data sources. So I'm putting in there, for example, the National Plan and Provider Enumeration System. Others of you probably are more familiar with this as the National Provider Identifier, or the MPI. The MPI comes out of the MPPES. And that is data that gives you information for any billable providers. So these are people who work in healthcare who have an actual number. And those numbers are very important to help us link across other data sets. The data that are collected in there are incredibly limited to basic demographic information. And again, it does not include non-billable providers. So non-billable providers would be folks who might be working in the direct care workforce, for example, or other aides or assistants type of titles. Who you mostly capture in there are going to be your physicians, some nurse practitioners, physician assistants, and maybe some physical therapists and occupational therapists. So as well as maybe some pharmacists. But the data are limited to folks who tend to have more higher levels of education. There are a number of data that come out of CMS, and they specifically have this catalog of provider data. That's data that's coming from Physician Compare, for example. Physician Compare provides kind of very similar data as what you might get out of MPPS. You have some basic demographics, information, age, gender, and maybe location, and specialty. And this data are certainly important, and again, helps you connect data across different CMS files. We have the provider of services files, which are also CMS based, and again, CMS is Centers for Medicare and Medicaid Services. Provider of services files are looking across different entities that receive funding from CMS. They provide information on the facilities that are receiving money from CMS. And so they can tell you things like how many beds, as well as how many staff might be in these different facilities. A challenge with this data is how they're collected and the frequency by which they're collected, which is that typically, especially, I used this data years ago looking at hospitals at a time when I didn't have money for the American Hospital Association data. And the data for hospitals, for example, were only being updated anytime the hospitals were encountering a problem. And in which case then they had to submit new information to CMS. The data are better usually for more of the long-term care settings like skilled nursing facilities, but they don't collect data on, say, home health services with much detail. And so the data are limited. There are other sources that are probably better for identifying some of these settings, but it's certainly a common source of information about some kinds of different staffing configurations in these settings where you might see patients being cared for with dementia. We have various states that collect licensure data, and there are many different configurations by which licensure data kind of exist out there. It struggles with the same challenge as some of the other data sets I'm discussing above here, which is that these are only for licensed providers. So not necessarily just billable providers. So it's a slightly bigger group of people who may have a license, but it does require that health professions are actually requiring a license, which may be which certainly is variable across the healthcare workforce. Not all healthcare workers are requiring a license. For example, nursing assistants may not have a license. They may have certificates, but that might not be collected at the state level. And licensure data vary in terms of how you can get it. Some states put the data all online with all the names and birth dates and gender. That information may be just on a website that you can find in multiple different places. It's oftentimes not in a single location because different agencies within a state may be licensing healthcare workers. So it's not like there's necessarily one repository of state licensure data in any one state, although some states have made an effort to do so. And that some states do put the data behind a paywall where you do have to pay a nominal fee usually to get access to this data. And I'll share a report at the end where we've certainly detailed some of this, some of these challenges and what you might find across states in a sample of states in a report that our center had produced some years ago. So state licensure data, again, is similar to MPI in the sense that it gives you a number that maybe you can connect some information about some person, but it has some limitations, one of which is that the data are constantly updated. When someone has a new when someone is newly licensed, that data becomes available on this website. So it's not on these websites or through the agencies. So it's not like there's some regular data collection period. It's just an ongoing update. But as a result, we may not have access to archived information. So folks have to probably regularly download the information if you want to see some more historic trends in licensure information. The other limitation is that sometimes license can go stale and people don't necessarily have it cleaned out. State agencies may not have folks who have expired license clearly marked sometimes in some of the publicly available data sources. So you'd have to ask for that information that might be, again, sitting behind the scenes. And the other issue is that people may be having a license, but they don't practice. So you really don't have a sense of whether or not people are practicing or not. There are a number of private and restricted data sources out there, and the AMA master file, the American Medical Association's master file, is one of them. It's another source of a licensure data set. It is a licensure data set of physicians or anyone with a medical degree. And so that suffers some of the same limitations as other state licensure data. There is a cost associated with it. Then there's health insurance claims data. If you have an MPI, then you can connect the dots between identifying a certain kind of provider and the kind of care that they're providing. Similarly, in electronic health records data, one could probably find some more information about a worker, and you can probably connect, if in your own institution, electronic health record data to, say, HR data. But these are more I'm just kind of throwing them out there just to acknowledge that people are using all sorts of data sources to understand the health workforce, but these are usually restricted data sources. They come at high cost. And many of you are probably collecting data with your own surveys. And I think one of the benefits of understanding what surveys might be out there is that as you design your own surveys to collect information on the health workforce, on the dementia care workforce, is that it's certainly worth looking at these different data systems to say, what can you learn from those data sets? What can you modify or adapt so that you can do some comparisons in your survey compared to other surveys that exist out there? And that's a way to leverage some of that public data, is by creating survey questions that are based on other validated instruments. So, for example, how you might collect information on race or ethnicity, or how you might collect information on gender, or sexual identity, or any of that information. No need to recreate the wheel. I would certainly say the advantage of those public data sets is that there's been a big vetting process to try to get these questions as honed in as possible, and you might as well try to build off and parallel your survey questions to look similar to some of the public data sets. And if you have opportunities to collect things like MPIs, to try to collect that information so that you can connect it back to other data sets. Okay, so I'm going to dive a little bit deeper into a few data sets that I highlighted earlier. They're public data sets, and I'm highlighting these mostly because I have the most expertise in these areas. I've used these data sources a lot, so I can speak to them a lot. But I think they're good exemplars for data that we can use to look at the dementia care workforce. So first, I do want to just acknowledge that there are many places to get these data sets, but ultimately the American Community Survey is coming out of the census. The census is the group that collects this data on a yearly basis, and I'll give a little bit more detail on the data. The Bureau of Labor Statistics is also an incredible resource for data on the health workforce, and that's where I'm going to dive deep a little bit on the current population survey, and you can get the data out of the Bureau of Labor Statistics. And that data are collected on a monthly basis. But the data, the way I usually get these data are out of a service called IPUMS. Some of you may say IPUMS. I've been corrected before that it's IPUMS. And IPUMS is a service that's out of University of Minnesota. And what's wonderful about their service, and it's a free service, is that you can go there and download their data. And they've taken the time to harmonize variable names and coding structures across multiple data systems, including CPS and the American Community Survey. The American Community Survey is that first box there that says IPUMS USA. That is the American Community Survey. And it's combined with the census because the American Community Survey basically is a replacement for the long form of the census that some of you may be familiar with. But it's a very easy to navigate website. You pull down the data, you pick your variables, you pick your sample size, and it pulls it all together into a nice, neat package of information in the forms of SAS, SPSS, and Stata. And it does some basic data cleaning, variable cleaning for you. And I highly recommend it. It's a wonderful service that does exist out there to pull down these data sets. And I do want to also mention that CPS, I do believe that the National Bureau of Economic Research also provides data for CPS. And so, and again, the advantage of IPUMS is that they do provide this harmonized information across multiple data sets. But NBER is certainly a place where you can also get data from CPS. So I'm going to compare a little bit across a few data sets, and this is modified from a report that my colleagues and I did looking at different public data sources that we can use to look at the health workforce. So it was not specific to the dementia care workforce, to understand some of the pros and cons. And this is, again, just giving you a sense of just some of the similarities and differences across these different data sets. So I'm comparing the American Community Survey with the current population survey alongside with the Occupational Employment and Wage Survey. And the Occupational Employment and Wage Survey is also coming out of the Bureau of Labor Statistics. And you can see from the top that some differences already start to emerge. The American Community Survey and the current population survey are household surveys. They are sampling households across the United States, while the Occupational Employment and Wage Survey is sampling employers. The sample size really varies based on which data set you're looking at. ACS samples 3.5 million households a year, and it is a weighted survey. And so it is nationally representative. CPS looks at 600,000 households, and that is equivalent to about 200,000 people. And then OEWS is sampling about 1.2 million employers each year. The way some of these household surveys work, and maybe you've been fortunate to actually provide information via these data collection methods. I recently actually received a document from Census to sign my household up for a future survey. So that is out there and it does exist. And what's interesting is that one person in the household responds for everybody else in the household. And you're answering questions about people's work and their income. So there is a limitation that's just inherent with the type of survey that's out there, is that you have to think about, well, who is responding to these surveys and how might they be responding on behalf of the rest of the household? A lot of times I take that for granted, that that maybe that there might be some response errors in here, response bias, because of the kinds of people who are responding to the survey, that as a result you may get inaccurate information if it's not the primary person in the household who's necessarily answering these questions. As for example, when I was asked a question about my husband's job title, well, I can come up with a job title. He wasn't here at that day that I was answering it, and I realized, like, oh, if he wasn't here at all, how would I answer this question? But then I started wondering, if he's not here at all, is he in the household? My husband works remotely right now, in another location right now, so this is a question that started coming up for me. But it's just some logistics there that's certainly worth contemplating about like what it means to answer these questions on behalf of a whole household. However, usually when you're using the data, you're really looking at an individual at a time, and each individual in the household is kind of treated as an individual observation. But at the same time, what's great about this is that you know something about the household composition, and you can look at all sorts of family dynamics. And this is where I would say looking at things like informal caregiving, or what someone's role may be where they're not working in a household that might be supporting an older person who's living in the household, might be a possible thing to look at. And it's not something that we've done a lot of in the literature, is looking at the household composition and leveraging that aspect of these data sets. The ACS is collected on an annual basis. The OEWS is collected biannually, and the CPS is collected monthly. So each of these data sets are collected with different timeframes in mind. The current population survey has additional supplements that they do on occasion with regularity. And a supplement that's worth noting is the ASEC, the annual supplement for economic studies. It doesn't quite line up to the acronym ASEC, but it is an economic supplement that provides a lot more detail on industry and occupation, as well as income and different sources of income. And the CPS is what is used for tracking unemployment in this country, but it's also one of the data sets that gives us really good information about income information. So despite it being a monthly survey with a smaller sample, it is probably one of a data set that is oftentimes used in many national discussions to understand economic trends, workforce trends in the US. What I particularly like about the ASEC is that they ask questions about what is your current occupation with a look back period of 1 year. So I call this a longitudinal survey in part, not because of that piece of it, but you can also follow that same person over essentially a 16-month period, where the panel design of CPS is quite complex. People are being asked questions for 4 months in a row, And then they take a 8-month hiatus, and then they come back later for 4 months more of questions that are asked. And you can link these 8 months of information that are collected on people. So you can also, instead of using the ASEC, where you look at this question of like, where they ask this question of what do you do this year and what do you do last year, you can actually just look at what did they report as their job last year, almost 12 months prior. So ASEC has that interesting component to it where you can see repeated responses over time and see changes at that level of nuance. There is a lag in terms of when the data come out. The ACS is approximately about a 2-year lag. So right now there's a 2021 data that's out, and we're in the year 2023. 2022 data should be coming out soon, but here we are pretty close to 2024. CPS has about a 3 to 4 month data lag. And I will say that there's probably about a month lag between when the Bureau of Labor Statistics puts it out and when it gets onto IPUMS. OEWS has about a 1.5 year lag. And so that's certainly worth noting. One thing I don't have here in this graph, but the COVID pandemic did have an effect on responses during this period of time. And one of the things is that there are some articles kind of written about this, but OEWS and CPS, given their complex survey design, weren't as affected as the American Community Survey. But there are survey weights that exist across ACS and CPS, and those weights can be useful to adjust for some of the low response rates that happened during that time. These data sets certainly have a lot of information around occupation, hours, wages, as well as other demographic information that's available in CPS and ACS. OEWS only really has hours and wages. They don't really have any other demographic information. And then there's a number of cross workforce codes that are certainly important to understand. And this is where I'm going to dive in a little bit deeper. If you're not already familiar with the concepts of standard occupational codes or national North American industry codes, it's certainly worth spending a little time on this. There's a lot of really in the weeds kind of information, but standard occupational codes is a federal way of collecting information on and standardizing information on occupations. The occupations that we tend to care a lot about are those that fall into the healthcare practitioner or technical occupations codes, as well as the healthcare support occupations. So this is where you might find the direct care workers, such as nursing assistants, home health aides, personal care aides. They fall in that healthcare support occupation. And this is just giving you a sense of like how many different kind of occupations we're talking about. There are many types of workers in healthcare, and there's a code for every single one of them. But anything that might be an emerging role are oftentimes not captured in these codes, and that's a limitation of using this kind of a system. Similarly, there are codes for the industry. They're called NAICS codes or NAICS codes, depends on your choice of pronunciation. And there are many different kinds of services and industries that exist out there, and this is just a sampling of them, just giving you a flavor for how many different kinds of services and industries that exist. And in the healthcare arena, where we tend to focus are the NAICS codes 621, 622, and 623, which categorize healthcare workers into these 3 broad healthcare settings. And you can already tell immediately that there's a little bit of a limitation that comes into how we define these different settings. And this is just a little bit more detailed to see what's underneath each of those codes. So codes upon codes upon codes, subcodes, subcodes, subcodes. These codes have some level of detail, but every data source that does exist out there has different levels of detail that they provide. Like the ACS and CPS provide this basically 4-number level detail, but other data sets like, say, for example, the Health and Retirement Survey can sometimes only have like a 2-code level availability of occupations and industry. You can certainly learn more about these codes on the Census and the BLS website. There are crosswalks between a set of codes that Census creates versus what the Bureau of Labor Statistics creates. You can certainly fall into a long rabbit hole on these topics. But I know I'm kind of getting short on time, so I certainly want to give some time available to Joanne so she can talk a little bit more about the different data, the new data that are coming, because that's super exciting. But I do want to just give one other quick tip is that these are, if you look at healthcare industry, The three different sectors that I mentioned above are falling into these three different categories. But one thing worth noting is that home health care is categorized as an ambulatory care setting. A lot of times, Joanne and I have spent a lot of time thinking about this, and home health care, I would say, should probably be coded and thought about as a long-term care setting. And there are many groups that are not captured, like retail pharmacies, insurance companies, manufacturing companies, public health services. And that's certainly worth noting. So I'm going to probably stop here. I just want to give a little bit more of a sense of just, I was just trying to give you a sense of how the different healthcare workers kind of distribute. And I'm happy to share my slides again with this level of detail. But I hope it gives you a flavor for what kind of data might exist out there, and the pros and cons of each one. And it just hopefully gets you going on some level of thinking about these data for the future for your own work. So with that, I'm going to pass it on to Joanne.
All right. I think my screen is showing properly. I hope so.
Yeah.
Thanks, Bianca. There are so many data sources, all of which are imperfect. And I'm just going to give everybody a quick preview of a new data source that will be coming soon to various data platforms near you. This is the National Dementia Workforce Study, a new program that just started. This is an $81 million cooperative agreement with the National Institute on Aging to conduct surveys of the long-term care workforce, or the workforce in general that serves people living with dementia. We officially started or launched on September 30th, and we will be surveying multiple different kinds of providers, clinicians of all types, licensed professionals, and direct care workers. And these data will be linked with patient outcomes and facility data to enable really rich research on both the workforce itself, as well as its role within the organizational context and in delivering high quality care to people living with dementia. There will be pilot grants available to accelerate the use of the data, and we will be sure the award network gets announcements and all the emails about that. So who is doing this? Well, first, Donovan Most, who is at the University of Michigan, is the contact principal investigator, and I'm multiple PI with him for it. We also have James Wagner, who is at the University of Michigan Survey Research Center involved, leading up a lot of the work on sampling. Laura Wagner, here from our award network team, is involved in the project. She will be leading up the pilot award core. And Stephen Marcus at University of Pennsylvania, who's involved in some of the data linkages issues. And then we have various other partners who are involved in this, who also are award network regulars. Mathematica is involved. The Alzheimer's Association is going to help lead community engagement. And we've got Bianca and Kezia on our advisory group, and Susan Chapman, or actually involved as consultants in developing the survey questionnaire, Susan Chapman from the award network team. And then we're kind of keeping Lei Chen in the loop because she's our fantastic postdoctoral fellow. So why do we need this? I actually am going to skip this slide. This is my standard slide deck, but I think everybody in the award network knows why this is important work. There are a lot of data sets with which you can try to learn something about the direct care workforce and the dementia care workforce in general, but the level of detail and specificity is lacking in most of those data sources. So I'll tell you quickly about the family of surveys that we'll be doing. The first survey, which we jokingly call the easy one, is going to be of clinicians. And this is going to focus on physicians, nurse practitioners, and physician assistants who have billed Medicare or Medicaid for any patient with a dementia diagnosis. For physicians, we're going to limit this to people who are in primary care fields, family medicine, geriatrics, neurology, psychiatry. It's possible in future years we might want to look at, say, oncologists who have a high load of patients with dementia. But for the first rounds, we plan to focus on the people who would be more involved in the day-to-day care of individuals. So step one is identifying the patients with the dementia diagnoses. Step two is going to be identify the clinicians who have billed them in any setting. So this could include clinicians who are billing for home visits, for nursing home visits, for hospitalist rounds. And we may also look at pharmacy claims to help better identify incident to billing for NPs and PAs. And then we will stratify the frame based on setting of billing, the volume or percent of dementia care patients, rural, urban location, clinician type, etc. And there will be over 5 waves, about 20,300 surveys conducted. Some of those will be repeat contacts to the same individuals. So there will be a longitudinal component to this. Those data then can get linked to Medicare and Medicaid claims. And I'll talk in a few minutes about how you can access the data as it comes through. The second in the family of surveys will be nursing homes. And these are, here the surveying process gets a little more complicated. We're going to identify nursing homes that have any dementia residents. So we'll start with a stratified frame of nursing homes, and that can be gained from CMS records, and then recruit facilities to participate in the survey. The participating facilities then will have a brief organizational survey about their organizations, and then we will also get rosters of their staff and survey a sample from those rosters and survey their staff. This is going to have 5 waves over 19,000 unique surveys, some of which will be longitudinal, asking, contacting people repeatedly. These data then could be linked to Casper, to the minimum data set, to the PBJ, and to other administrative data. And we will be encouraging nursing homes to participate in the Long-Term Care Data Cooperative electronic health record database based at Brown University. And if they're already participating, we'll link them. That'll make it easy. And if they're not, we're going to encourage them to participate, and we will be trying to link those data if possible. So then we'd have EHR data linked with some organizational information, as well as these unique surveys about their workforce. How cool is that? Assisted living is the third in the family of surveys. This is going to have a fairly similar process as the nursing home surveys. However, identifying facilities is harder. And fortunately, we have Cheryl Zimmerman involved in the team, and she knows more about assisted living facilities than anybody I know. And so she's providing tremendous guidance in our thinking about how to do this. But a similar process of identifying and recruiting facilities, doing short organizational surveys with them, rostering their staff, and sampling from those rosters. This is going to be over 15,000 unique surveys, some longitudinal. And the Long-Term Care Data Cooperative is aiming for having an assisted living database. So we will encourage facilities to participate in that as that comes online. And we are going to work with the facilities to learn about what other data we can link. If it is possible, without being a giant HIPAA violation, to come up with confidential, secure links to Medicare and Medicaid claims, that would be the ideal. The final in the family of surveys is going to be home health and home care agencies. And honestly, we are still trying to figure out how to develop a sample frame for this. Because I think as Bianca highlighted in looking at the various data sources, there are a lot of ways to define this workforce. There is a lot of this workforce that is employed independently by households, and it's really not obvious how to find them. So we're looking at a few different options, and we are probably going to try to implement more than one option in our first year, which will be really kind of an expanded pilot with the goal of producing usable data as well as learning about how to best access this workforce. So we're looking towards working from a sampling strategy involving home care agencies, which would look very similar to how we would approach nursing homes and assisted living, but then also potentially looking at Medicaid claims to identify LTSS services being billed to Medicaid. Those billings are going to come from agencies, and then that would provide a pathway to approach those agencies and potentially link the data back to Medicaid and Medicare claims. Again, over 20,000 touches over 5 waves, some longitudinal, and trying to figure out how to link this with patient outcomes is not obvious, and we're going to figure it out. So making the data accessible is really essential. This project is a lot like NHATS or the Health and Retirement Survey, where the main purpose of this program is not for Donovan and I to get to do really cool research. It is for us to create a national resource for all of you to do research. So there will be public use files, primarily of the survey data, unlinked to any resident or outcomes data for the patient and population level data. The first unweighted files we aim to have available in August 2024, and then full data sets would be available in early 2025. There will be restricted use files that have linked data that will be available. We are aiming to have those available through the linkage platform, which is the NIA supported platform, through which you can access other linked confidential data. We will have pilot awards to encourage your use of the data, being early users. There will be webinars and information systems sessions about the data. There will be annual data user conferences, and we are beginning to talk about having kind of data training sessions in conjunction with other national conferences where we know many of you attend regularly. So stay tuned. There will be a website shell going up soon and a larger website later that will have more information about the data. So I'm going to stop there because I know that our fantastic postdoctoral fellow, Lei, has a little bit more information about new data to share.
Yeah, thank you so much, Joanne. That's so exciting. So Lei, yeah, please, if you can share a little bit about the work that you're doing with us, that'd be great.
Thank you, Bianca and Joanne. So I will give you a brief description about the data companion work for the award network. So Kyoko, who is a research assistant at UCSF, and I are developing a research-ready harmonized data set of policies and programs that affect demand, supply, working conditions, and the skills of direct care workers. And we are working on several examples of policies and programs, such as state Medicaid waiver programs, wage pass-through laws, and other 5 topics of policies and programs. So for each of these policy and program, we will start describing the policy and introduce how this policy was applied in each state. We will refer to some government and research institute reports and policies. Then related to this policy and programs, we will list the data sets related to this policy area. The information include the time period of this data set data collection and the related topics and type of data set, whether it's free or public, and some related variables will be listed, and also some example of published articles using the data set. Also, we will provide some limitations of this of using the data set and whether the data set will be included in our harmonized data set. So what is a harmonized data set? So we plan to organize and compile some data sets related to this topic in an Excel sheet for users to download, and including the research-ready data and some technical documents, such as the list of variables and their informations. So we right now have a brief description of the data compendium on our website page, and you may feel free to check the web page about what I just described. So yeah, we hope to share our first topic of state Medicaid waiver program very soon. So you will see the example of how we organize the data compendium for each of this policy and the program. And also we hope to, yeah, that would be great if we can get the input and feedback from our award members, especially if you think if there are other topics and programs you are interested in, but we haven't included in our data compendium right now, or if you have used any of the data sets before and you may share your experiences, or whether you have some unique thinking way of the benefits or the limitation of using this data set. Yeah, all this feedback and the input were very welcome. So we may send out a survey, or later we will present our data companion progress in our summer institute or other conferences or events. So please stay tuned, and we will have more information to share. Thank you.
Thank you so much, Lei, and for you and Kyoko's hard work on pulling this data compendium together. I know we don't have very many minutes left, and I don't see any questions in the Q&A box, but I do want to encourage that if anyone has any questions, you're always free to email me directly. My email is bfrogner@uw.edu, but we also have an Award Network email address, awardnetwork@ucsf.edu. So if you have any questions about any of what we presented today, feel free, of course, to email that email address. And then our website, we are doing our best to make sure that all this information is available there. So that's certainly a great place to check out. We are really excited. I'm really excited to hear about this work that Joanne and colleagues at Michigan are doing, because as you can see, they're trying to add to the public data sets that are available out there, and trying to make these kind of pie in the sky linkages that we've always wanted between the workforce and the different health outcomes connecting to electronic health records and claims data. So thank you to all their efforts. And we all want to make sure that you are all successful in this area. So any way that we can help identify more data and ways that we can be helpful to you, we want to hear from you. So again, awardnetwork@ucsf.edu is a great way to contact us. And we look forward to hearing how you all end up using this data in the future, maybe at future webinars. So with that, thank you so much, everybody, and have a wonderful day.